then we'll hopefully move the microphones to be closer to people's mouths and do something on that. Hopefully there'll be time for questions at the end as well. Can I just remind everyone to sign the petition if you haven't already done so at the table, and to sign the TTIP postcards asking David Cameron to keep the NHS out of the trade deal. Okay, so we'll start now. So our first speaker, I'm looking over, but I know I have to speak into the microphone as well, is Andrew Donald. He's Chief Officer for Cannock Chase CCG and Staffs and Surround CCG, and Programme Lead for the Transforming Cancer and End of Life Care contract.
Okay, thank you very much. Can everybody hear me? Yeah, great, okay. Just to say thank you for inviting us to be able to sort of just talk to you for a few minutes. We've been told we've got 7 minutes, so this is going to be very quick. I guess a couple of things really. I am the Senior Responsible Officer for the Transforming Cancer and End of Life Care programme, and a couple of things I want to say about that programme. Absolutely, the programme is about patients. It's about patients, users and carers. The programme has been developed over the last 2.5 years, and it's been developed with members of the public. And what we've tried to do over that 2.5 years is work through some of the issues that the public actually face in relation to cancer and end-of-life care services. And what people tell us is that systems don't work as well as they should do. The care that people get from providers, from hospitals, from community services, they say is generally good. But the problem with the system is it doesn't actually focus on the patient, it focuses on the system. What we've also found is that people tell us that their loved ones who've unfortunately died have some very poor experience. They don't get a choice of place of death. They don't really get listened to in regards to what their needs are in that phase of care. And what we're trying to do is redesign that system so it is integrated. And in terms of integrating it, we're using patients, carers and members of the public right throughout the programme. So for example, we've got a group of patient champions. We're recruiting more people to those patient champions roles. What we're also doing is getting the patients as part of the procurement process, because the way we're looking at developing services is to look to a coordinator of care. So an organisation who will work with all the providers to coordinate care. And if I give you an example of that, in end-of-life care we have 36 contracts across Staffordshire with 36 different providers. They all provide reasonably good services, but what they don't do is they don't work together. And what we're trying to do is find a way of making sure that services are integrated in a way that will be helpful. There are 2 or 3 things that you may not know about this programme. One is that the goal is about patient seamless care from early diagnosis, because one of the problems is cancer diagnosis, people get diagnosed late because we've not got the systems for early diagnosis. And what we're trying to do is build a system right through to recovery, because by 2030 and over 4 million people will be diagnosed with cancer and be living with cancer, and lots more people will be surviving, and that's really, really good news. We also want to make sure that all the resources that are going into cancer and end-of-life care are used as effectively as possible. And as a commissioner, I can put my hand on my heart and say, you know, we don't use them as effectively as possible, and we don't get the best out of our providers. And what we're trying to do is get the best out of our hospitals and our community services. There are 4 clinical commissioning groups involved, and we're also working with the local authorities. We're working right across what we call the NHS pathway, and that NHS pathway is right from GPs right through to specialised commissioning. And we've got the support of Macmillan Cancer Support. Macmillan, what they're wanting to do is help us transform services. We continue to talk to patients and carers, we'll continue to do that, and we will continue to adjust things. And I'll say one last thing. This is on a large scale, it is big, but it's something that actually is about transforming systems, not just tinkering at the edges. Thank you very much.
Thank you, Andrew. Our next speaker is Dr. Jonathan Shapiro. He's Clinical Engagement for the Transforming Cancer and End of Life programme.
It's a long title. I'm going to basically say the same sort of thing as Andy said, but perhaps phrase it slightly differently. I come from a medical background, and I've worked through the NHS for my entire career. So I know it inside out, both as a non-exec side, I've chaired a trust as an academic, and I can't make sense of it. So I'm going to start in a completely different way and talk about a personal experience which I hope will resonate with some of you. My father died about 3 years ago of prostate cancer. He was 90 and he'd had it for some time, and in that sense, you know, we have to die. Each aspect of his care was technically fine. He had services from the GP, he went to outpatients, he had surgery, he had chemotherapy, he was given medication, he had appropriate follow-up, the district nurses saw him, he had palliative care at home, he needed to get some private help to cover the times that the district nurses couldn't come, and he died in a hospice. So a lot of different elements in that, and it sounds great, until you begin to dissect how and where it all happened. So they live in London, they live in North London in Hendon. The outpatients was in Barnet, that's 5 or 6 miles away. He's a man in his late 80s. How do you get there? The surgery and the chemotherapy were at University College Hospital, which is in the middle of London. Another journey on the tube or an ambulance or a taxi, completely uncoordinated. The medication follow-up was in a hospital not far from UCL, again, in the middle of London in St Pancras. The district nurses did come, but they were coordinated by phone from the CCG, so there's another set of negotiations and discussions to be had. Palliative care was provided by Macmillan through the CCG, again requiring all sorts of conversations and discussions between two old, confused people and their carers. They had to find the private carers to come and take him out of bed and put him into bed and so on when that was needed. And finally they had to find the hospice bed, which again was 10 miles in a different direction from home. So a lot of different things to do, and they had to do it all. It wasn't joined up, it wasn't coordinated, it was dependent on them and the rest of the family. And believe me, I know the system. I've done jobs in all these, I know the chief execs of most of these organisations on first name terms, and I couldn't make sense of it. So in that sense, the system, be it technically okay, isn't working. And here we know that in Staffordshire, death rates from cancer are actually worse than most other parts of the country. So I'd ask you to reflect, how many of you had similar experiences with loved ones, with friends, with family, with parents? I guess that most of us had the same thing. And the point is, this is where Macmillan comes in, because they were told exactly the same by both users, people who are actually accessing Macmillan services, and by their staff. So when people accuse us of not having user involvement, that's rubbish, because the starting point for this is Macmillan hearing from their users. And they decided that rather than tinker at the edge, they'd have a completely different approach, and they would find a different term here, a service integrator. Someone who not necessarily provides the service, but becomes the conductor of the cancer and end-of-life orchestra. If you imagine that the surgery is the violins, and palliative care is the woodwind, and some other aspect is the percussion, someone has to hold that ring together. It's a job that was traditionally done by GPs, but GPs are now very busy, and I wish we could get them to do more of it. But it's not being done, and that's what we're looking for, it's the conductor. So the nature of the project is to delineate exactly, to mark out what it is we want done, then find people, NHS, non-NHS, voluntary sector, private sector, where people who can do it, who've got the expertise, who can show us the expertise, make sure they understand that this isn't a simple thing like moving furniture, this is a highly complex thing to do, and then make sure that they accede to what the commissioners want, so the control remains entirely with the CCGs, and then they'll be monitored and managed. Finally, I just want to address this issue of the private or public sector, because there's a lot, and it's a diverting discussion, because this isn't about privatisation, it's about improving services. And I'll demonstrate that. I'll go back to that list of services that my father used. GPs. GPs are private companies under contract to the NHS. They never have been part of the NHS. They are paid by the NHS, they're controlled by the NHS, they're private companies. Outpatients, the operations, all those things are purely NHS. But they're supported by a lot of other organisations. The catering, the transport, the communications, the back office, all that is done by all sorts of different organisations. It's seamless in the sense that it comes out as you go to hospital, but it's from all over the place. Palliative care is done via Macmillan. It's a voluntary sector organisation, it's not the NHS. Hospices are a charity, again funded elsewhere. So the reality is that the NHS has always been, and the important bit here is it's publicly funded and publicly controlled, but it's always been able to let contracts where it wants. So I would say to you, to finish, as long as it's publicly funded and as long as it's publicly controlled, Do we need to change the way the NHS has always worked? This isn't new, the way it's always worked. And in the end, are we more concerned about giving ourselves and our families good care, or are we going to be more worried about who holds the carers' contracts? Thanks.
Thank you, Jonathan. Sorry, our third speaker tonight is Rob Flello, who's the MP for Stoke-on-Trent South.
Thank you very much indeed. Good evening. I'll do my best to stick to time, you know what us politicians are like. I think first of all it's important, can everybody hear me okay? Yeah, marvellous. Okay, I think first of all it's important to make clear the context in which this is happening. Before 2010 we were told there would be no more top-down reorganisation of the NHS. And then what happened? The 2012 Health and Social Care Act came in, which was the biggest reorganisation from the top of the NHS. In its history, thousands, I mean thousands of clauses of that bill received no scrutiny at all, were brought in. £5 billion has been spent, wasted I would argue, on reorganisation, getting rid of PCTs, bringing in CCGs, all of which means the eye has been off the ball in terms of things like patient care. We now have an NHS that is creaking at the seams because of the savings it's been required to make and because of the changes that are there, because, for example, here in Stoke-on-Trent in North Staffordshire we don't have enough GPs. So we've got this huge problem in terms of what's going on now. What is the solution that we're being offered? We're being offered the solution which is always offered by the Conservatives, which is to privatise. So in this case, it's selling off cancer and end-of-life services here in Staffordshire, including Stoke-on-Trent, for a sum of £1.2 billion. Biggest auction of its kind in NHS history. It's important to note as well that all major NHS contracts so far, since this Act, have been awarded to the private sector. And if this goes ahead, as I'm sure, unless we can mobilise and stop it, it will, what we'll see is the private sector taking 5% of the total NHS budget for this area. Now, just to put some personalised figures on that, the value of the contracts is something like £1,600 per person. The expectation is something like 30 to 40% of that will go in management costs and fees. That's almost £500 per person, not on care, not on patients, on fees. This privatisation, and that's what it is. If it looks like an elephant and sounds like an elephant, it's an elephant. This is privatisation. Will damage irreparably the NHS that we have, will damage patient care in this area. Let me have a look in more detail, if I may. I'm trying to stick to the time. What is the situation? Well, for almost 70 years, we've had what I think is the best healthcare system in the world. But what do I know? Well, what does the New York-based Commonwealth Fund know? Well, it knows that this is the best of its kind in the world. The government has no mandate to sell off our NHS to the private sector. It said it wouldn't reorganise, it did. And this is only one of 14 projects of its type in England. I think we're being used as a guinea pig for untried and untested ideas on ideology, not on best medical practice. Now, in terms of the area we're talking about best part of 767,000 patients, so 750,000 patients affected by this. It will let the private sector genie well and truly out the bottle. You will never get that change round. Some of you will have seen, there's this transatlantic trade and investment partnership negotiation, this free trade negotiation. You might think, well, what's that got to do with us here in Stoke-on-Trent in North Staffordshire? Well, what it will do is it will permit American healthcare firms, and we all know what a great reputation the American health system has got, to bid for UK healthcare contracts. You can't stop them. It will be in that document. They will be able and they will be entitled to bid. Now, my criticism, and it's not only mine, but many of us, say that what we should have is patient care, not profit. It shouldn't be about wrecking the very founding principles of the NHS. I don't think personally it's morally right to profit from cancer and end-of-life care. I think money that's going into the health service should be there for patients, not shareholder interests, not the interests of private companies. And if we looked at this system, we're talking about a 10-year contract. Now, it's been referred to as a break clause at year 2. It's not a break clause at year 2. The first 2 years are seemingly how to get the evidence as to why all this is a good idea. So that's not a break clause. So what then happens, of course, is the company that gets the contract says, oh, well, we've gathered all the evidence as to why this is a good idea, and surprise, surprise, it shows that it's a good idea. We're now going to have the next 8 years of delivering this contract. And if you say we can't, well, A, we'll point to the evidence that says we should have this contract and that there's a need for it. And secondly, well, you haven't given us a chance to show what we can do. So you've got this crazy situation of seemingly a 2-year break clause when reality is it's not a break clause at all. What will happen in practice? Well, the private provider will cream off the high volume, low complexity, profitable work, and anything that's left, the low volume, the complex cases, the ones that we really are worried about, the level of quality of treatment, well, they'll stay within the NHS. And an NHS, of course, will not be able to afford it, because all the high volume, perhaps the low complexity work that in this world that we're supposed to call a health economy has all gone off in terms of profits elsewhere. So I think this would be an absolute act of reckless folly. Now, Macmillan Cancer Care, they told me it was their idea that they approached the CCGs about it. And they seem to think, and as we've heard this evening, that it's somehow impossible for the CCG to hold people like Mark Hackett, the Chief Executive of the University Hospital, to account. So, OK, 2 observations. If the CCGs can't hold people like Mark Hackett to account, and as Mr. Donald said, they can't get the best out of their providers, well, can they please explain why they have staff to do that? And quite frankly, if we're being told that the CCGs can't hold to account the people that have contracts, then why are they doing it? Why are they doing their jobs? Why are they not standing aside and let somebody who can hold these contract holders to account? And why on earth do they think it would be easier to hold a private provider to account, to hold a private provider to account themselves, when they can't hold the likes of the UHNS to account? And how would they expect... And again, why is it that they think that a private provider can hold the UHNS and others to account? It doesn't make any sense at all. And I would just pick up on Dr. Shapiro's point about the conductor of the orchestra. I would say the CCG is the conductor of the orchestra, and what they're talking about is farming out that conductor's job to somebody else who may well sack the entire orchestra and bring in other players. So none of this makes sense. I've got loads more I want to say, but obviously I've run out of time. I think just to pick up on a couple of points, we've been here before. Burton-on-Trent, only inpatient psychiatric unit, the Margaret Stanhope Centre. Mr. Donald, when he was in charge of the PCT, ignored the 8,000 petition signatures that wanted to keep that open. It was closed. I hope this time he will listen to the 10,000 plus signatories and keep it open. To close. Are there issues with the services? Yes, I've got family members who are going through cancer care at the moment. There are issues with the services. Is it that there are individual problems or an overarching problem in terms of this seamless service? Well, actually, from both personal experience and the casework that I've dealt with for the last 9 years, it's been increasingly, particularly over the last 4 years, individual providers that there is the issue. Why is that? Underfunding, a focus on reorganisation, problems with things like the mid-staffs, not enough GPs. Issues we know that are problems, that's where these CCGs should be working to solve it. Is the solution privatisation? Absolutely not. No.
Okay, thank you, Rob. I will now pass over to Rachel Maskell, who is Head of Health in Unite the Union.
Last year, 318 people in the UK learnt that they had cancer, and 535,000 people reached the end of their life. Many more needed integrated care. The fear of the journey ahead that goes with any diagnosis will be made known to many of you in this room tonight, but the comfort of the amazing love and care of skilled NHS staff helps see you through that journey and gives you the confidence that only you matter on that journey as you go through that path. Of course, not everything is perfect, but we have to learn and work together to make it perfect. And there is no reason why a private provider, a provider that may focus on trains or prisons or buses, as we're seeing these companies come more and more into the NHS, why those kind of companies should be able to provide a better service than the people who have worked in the NHS for the 66-year journey that is forever evolving, putting patients at the heart and giving patients that hope to carry on their fight. You can be confident that all NHS staff want to remain in the NHS. They don't want to work for other organisations. They don't want to be pulled to other people's agendas and to the agenda of driving profit out of the sick. They're there because they care, they want to stay there, and with your support they jolly well will stay there. You see, the deal was struck. Health services you don't as patients see the calculators, and they don't see your credit cards. After the protocol assessment was simple. You pay your stamp, and those who are unfortunate enough to be called out, who are sick, they will get the best available treatment. That principle has held for 66 years, and we're going to make sure that it continues. Learned from this process is that the NHS is fully accountable to us, the people. We pay for it, we own it, we hold our politicians to account for the running of it. What we have seen, even in these stages of the process, is the lack of transparency, the covert procedures, the not wanting to break confidentiality, commercial reasons overriding public interest. If even at this early stage of a tendering process we're seeing that, what happens when part of the service goes wrong? What happens when you've got problems? Who do you go to? Who is accountable? How do you get those problems solved? The private sector will forever come back and say that things are commercially sensitive and that you have no right to question, and ultimately you are not able to sack those people that provide the services. At election times, you call your MPs to account. Who will you call to account when this service fails you? That is why we cannot allow the private sector to integrate into our health service. It has no place there. But the whole thing about commissioning is about you being at the centre of the process, your voice being heard through a process. Written into the legislation, it says there has got to be consultation in that process. Andrew Lansley, with the passing of the bill, said, no decision about me without me. So one thing that I would say to the commissioning team is there is a very clear voice coming right across Staffordshire that we do not want private involvement in our NHS and providing those services.
Yes. Even simpler for you. Stop the tender. That's what we want. Stop the process. Of course, let's work together, let's get the service right, but there is no need to go down this line of putting this out to a commercial enterprise to see the way that probably just the finances fall in the end. What we know is 10,000 people across Staffordshire have already stood up and said no. It's a simple thing for you to respond to a consultation. You will not have those numbers saying, yes, please privatise our services. Ensure that service remains within the NHS, respond to what the people have said. That is what consultation is all about, and keep our NHS public. Already the motive of these private companies, profit. That's what drives these companies. We already know across the NHS in the UK, 500 contracts have gone out to the private sector. £13.5 billion worth of our taxpayers' money handed over to private companies to squeeze out even more money to generate profit for shareholders. That's why these companies exist. They don't have expertise in various areas of cancer. We don't need the conductor as being described coming from a private sector to see how more efficiency can be driven out. What we need are the experts, which are patients, which are staff of all staff right across the NHS. You talked about some of the range of staff working in the NHS. I can tell you, porters as well as doctors have got
resolutions that can be brought into how services can be better provided. We know that nurses working at the front line know how services can be better provided, and therefore what I would say is talk to patients, talk to carers, talk to the range of health providers, and we will tell you that working together in an integrated health way is the way forward, because nobody has just one area of health that they're concerned with. We work in an area of comorbidity, we work in an area where people aren't siloed into a particular health condition. So why privatise part of that service and not the rest? All it brings is fragmentation, and ultimately that isn't about putting the patient at the centre, it's about putting the interests of various organisations at the centre. Yes. We're not going to have that, and we will stand up against it. What I would say to the commissioners as well, why rush this through? You've already set out a scene, 2.5 years of preparation, 2.5 years of discussion. I'm sure some of that has been of real value, but we have just 154 days to a general election, and we know that after that general election, every indication is that the landscape will be entirely different moving forward, that there will be an NHS restored again across the country, and therefore what we would say is just hold off for those few days and let's see what comes from that election and then make the decision after that. There is no need to rush through the process at this late stage. Political decisions aren't made in these times, and we were calling you not to do that. What we need to ensure is that we have a secure system moving forward in a very integrated way. The average cost of cancer treatment for a patient is £30,000, and we know the price will rise, and we know that people in this room will never have the means to dig into their pockets to pay for that service. However, what we are starting to see from many of these private companies running services is that they're now asking for top-ups, for additionality, for people to pay a little towards it. I was on a ward just at the weekend and I saw a payment card machine on that ward. I couldn't believe my eyes. This is the way that the private sector starts impinging on what is our right, our equality, and of those principles that Bevan put into a service back all those years ago when the health service was created. And a final point about these private companies, and Unite has been particularly in exposing some of that, but many other organisations too. These private companies are not reinvesting the money that they generate back into the health service. They have tax havens overseas where they are hiding behind their finances. We know that they have loads of different vested interests, including with number 10 and this government. And we know also that the model that they're remodelling and reshaping their finances in a way that they're having private equity companies running these companies, so they have a very, very opaque way of operating their finances. And as a result of that, we've seen what happens to when the care system failed and people, elderly people in this country were left without homes. We've seen what happened with the banks and the way that the casino bankers drove that agenda. And we cannot allow these private equity companies to drive that into our health service. And therefore what I would say is we have to keep our health service clean. It is a clean service at the moment, and therefore moving forward we have to maintain the NHS, our NHS, the one we pay for, the one we provide, the one we work in, the one we own, the one we built, to stay in our hands.
Okay, our final speaker for tonight before I open questions from the floor is Dr. John Lister. I shall allow him to introduce himself. He's got rather a long title, so I'll let him pick which one he wants to tell you.
John Lister, I got here by annoying people for 30 years, basically. So I'm not going to go through a long rigmarole about myself, because I think there are very important issues here. I think there's four main areas of concern, and the first one I want to raise is democracy and accountability. This is the most incredible process. It's being run, the tender for these services, which are extremely important, is being run not actually by the CCGs, but the Special Projects Group for the Greater East Midlands region, which is actually based in Cambridge. They're running it, all the applications go to them, they're surveying it. What's the basis on which they're going to judge the applications at the end? The criteria, it's a one-line criteria basically, award criteria, the most economically advantageous tender. Cheapest. Cheapest. Yeah. How is that a basis to improve the quality of council care? I think it comes as a shock to a lot of people to find Macmillan, which a lot of us see from the adverts on the TV and from elsewhere, as a charity that actually does a tremendous amount of good work, is actually driving this process towards bringing in private sector providers into this process here. And before they deny it, well, obviously they constantly deny it. It's a mainstream of what they have to say on their website and everywhere. It's not privatisation. If you set up a system in which it's acknowledged that, in fact, the main local providers, because of the situation they're in with the financial pressures on the NHS and so on, are not in a position to tender a full bid themselves. If you go into that process and rush it through, knowing that they're not in a position to tender a bid, who's going to be putting the bids in? There's no secret there, is it? We know who they will be. Ramsay Health, Virgin Care, Care UK, all the people with their hands out and searching for a quick buck out of the NHS. They'll be the people, because they've got the resources to do that, and they're actually there shopping around looking for more ways in which they can get a foot in the door and a share of the £100 billion a year spending on the NHS. So they will be putting bids in, but the NHS, local NHS providers are disadvantaged. So what do we mean by privatisation? We mean something that has been provided by public sector organisations being delivered by private sector organisations. And in this case, we're looking at the commissioning of services, which at the moment is supposed to be done by the CCGs. In these particular cases, they hand over the commissioning of those services effectively to whichever bid succeeds, but we can assume it will be a private sector bid. So we're getting a substantial abdication of responsibility by the CCGs to whoever wins this bidding process on the basis of being the cheapest. Now, how does anybody really think that's going to improve your cancer care or end-of-life services in Staffordshire? This is just a complete and utter nonsense. And the more you look at it, the more you realise that you're being denied information on the key questions. Why is it that all the documents about this process are being kept secret? What is the reason why the pre-qualification questionnaire, which is being sent out to companies expressing an interest, we can't know what they're being asked? That's the basis on which these companies are going to be evaluated and shortlisted as to who's going to win the final bid. We're not allowed to know what's in that document. It's kept secret. And it will be kept secret until after the process is finished, and then they'll produce a redacted, they call it, blacked out, a whole section censored, which you are not allowed to see. And we're told one of the reasons in their engagement document, one of the reasons they have to keep all this secret is to protect the commercial interests of the CCGs. What are the commercial interests of the CCGs? These are supposed to be public bodies running an NHS, which is a not-for-profit body. What are the commercial interests that they have to protect? What have they got to hide in these documents they're afraid for us to see? That's the question. And the other question, which is really hits you in the face, what do they want to achieve? What is it they are looking for at the end? We've got the definition at the beginning from Andrew Donald. Patient seamless care. Well, great. What does that mean? What does it look like? What actual services do they want? There is no plan here around which they are going out and putting out a bid. Or if there is, we're not being told what it is. Now, either there's no plan, in which case, what a scandal. All this money being spent on these services, they don't have a plan of how to improve it. They're just kicking up in the air, hoping some private sector person or other can come along with a suggestion as to how they might run it better. Or they have got a plan and they won't tell us what it is. Well, I think that's pretty bad as well. So either way around, we've got a real big, serious problem. There's no business case. There's no evidence to show that you can actually improve beyond what you've got by this process, rather than the more obvious one of going to talk to the local NHS providers and negotiating with them how they could do the job better. But that, of course, requires you've got a plan. Maybe these people just haven't got a plan. They're hoping Richard Branson or somebody will offer them a plan in order to get them through the process. And then we've got the most absurd thing of all. They're proposing this massive change, and they're saying they don't want a public consultation. And in fact, they've spent NHS money going to lawyers to get a finding that maybe legally they don't have to have a consultation, therefore they won't. And the finding is based on the fact that there's no real change in services from the patient's point of view. Yet we're told again this evening, they want to transform these services. They want to completely change the way in which they're commissioned and delivered. So which way is it? Are there no change at all, in which case, obviously we don't need a consultation because nothing's going to change, and presumably you can stop the tender because they're not going to change it, or there is a transformation, in which case, why can't you, the public, be given a voice on what those changes are, and be told what the plans are, and being told the basis on which people are being invited to tender? That's absolutely basic. And it's just utter contempt for local people to actually treat them this way, and to start saying, well, you don't need to know that, this is for us to know and not for you. That's effectively what you're being told. So, and the other thing is, a 10-year contract. A 10-year contract, 2 years of which will be minimal change because there'll be effectively the new company or whoever it is will not actually be effectively in charge, and then 8 years in which there is no break clause, in which they are then given carte blanche to do what they like, having won the contract. 10 years, that is a radical change. That is a very radical change. There's no other 10-year contracts anywhere in the NHS. So 10-year change is a big deal. Do we want to sign away the control over local cancer and end-of-life services for 10 years to a company we don't yet know who they are, we don't yet know on the basis on which they've been invited to participate? Do we want to do this? Do we trust these people? Do we really believe they're telling us everything? No, I don't think you do. And I think this is actually... No doubt will later be referred to the website. Has anybody looked at the website? Can anybody read anything on it? What the size of print on there, the colours of the inks that won't print on a printer. There's a diagram of what they want in the end. These patient champions that are being referred to, slot in. Can anybody work out what they're supposed to do or how they have any impact on anything? There are people who are called a patient champion. They're no doubt patronised and trained and told what to say. But what they actually do is not at all clear from the diagram. I wish I could just print it out and show you, but it's completely invisible when you actually print it on a normal printer. And so, this is a website that actually conceals more than it reveals and doesn't actually take you very far forward. There was no need for tendering. And in fact, Devon CCG, North East and Western Devon, the biggest CCG in the country, has just implementing a substantial change in services, which is actually controversial, but they're doing it without putting out to tender at all, on the basis that Monitor says you can actually make changes like this if it's against the patient interest to open it up for a wider tender. You can do it. It can be done. They've chosen to go down this route, egged on by Macmillan. This is actually not the way it needs to be done at all. And the private sector, as Rachel has said, is completely inappropriate anyway for delivering patient care. They deliver no complex surgery. They deliver no high-risk surgery. They deliver no emergency surgery. They pick and choose the simplest cases up and down the country, absolutely consistently. And what happens when they can't make a profit? They walk away. They walk away and leave the services in limbo. That's just happened with Serco in Braintree in Essex, a community hospital. They couldn't make the money they wanted, walked away and left the NHS to pick up the pieces. If a company takes over this 10-year contract and walks away after year 3, what happens? Who picks up, what's the plan B? Who picks up the services? You'll presumably by that point pulled the rug from under local trusts, made it impossible for them to take it over anyway. Who takes over? We face a collapse of those services if that happens. And that could easily happen because the private sector is making no money. Serco's just realised that they're losing money on all their contracts and pulled out of any further tendering. So we won't have to deal with them on the shortlist. but then we've got Virgin is losing money. Circle is losing money. All the companies you've heard of with private contracts are losing money on their NHS contracts. Now, how long are they going to carry on doing that? At the moment, it's lost leaders, hoping they build up enough body of contracts to force the price up. What happens when they find they can't? Then the system goes horribly wrong. By that point, you've destabilised the NHS, undermined local services, broken it and fragmented it still further. Far from integration, this is a formula for smashing local services further into pieces. Look, this is a disaster waiting to happen. And it'd be very interesting to know if any of the GPs actually support this. If you look at the 4 CCGs involved, there's a grand total of 18 GPs on the boards of those CCGs. Just 18. There's no evidence at all. They've consulted their GPs, they've got any support from those GPs. I would say a very basic starting point before you go any further at all, have a ballot of every GP in the 4 CCGs and find out. And if you can't produce a majority of GPs up for it, then scrap this scheme. And let's also have a proper consultation, and let's have the council step in with the oversight and scrutiny committees and demand a proper consultation, demand a business case, demand the CCGs do what they're supposed to do, and explain the situation, and explain their plans to you, and then seek your support. And if they don't get it, they should drop these plans as well. So in other words, stop it now before it goes horribly wrong. And what's the hurry? Take your time. If they want a serious discussion about services, have a serious discussion, not this hole-in-the-corner secret manoeuvre. Thanks very much.
Thank you, John. We'll now be taking questions from the floor. I think we've got some roving mics. I will ask that you make questions rather than long speeches. Obviously, I know you might want to do a background. I can see you, so you're right. I'll go for you first. What I'll do is I'll ask 3 questions, and then we'll people at the top table can respond. So I'll do you in groups of 3 first. The gentleman down here first, the lady in the red top up there, and the gentleman who's being pointed to at the back. Oh, is that lady? I'm sorry. With the black top? Yes, waving at me now. So if we go here, there, and then back there. Okay? Yep.
Thank you. Hello everybody, my name is Jeff Berryman and I live in Stoke, and since I'm limited to questions I'd like to go first with Dr. Shapiro, because I don't recognise what you described. You described London. There's nothing to do with us up here. What you described was London as a dysfunctional city. We don't want those circumstances here. They have no relevance here. I can tell you what happened to me, so my question, please, is what on earth has the situation which your dad experienced in London got to do? He wants to have my experience, which I had in Stone when I got cancer 3 years ago. Am I allowed anything else?
If you just repeat what the question you'd like to ask him.
Well, the other question was, you say, to ask him why he thinks that splitting up the health service, you've said it's gone over a long time, and all sorts of things have been put out. I was in hospital when I was about 8 for a week. My meals were produced in the hospital kitchen. My ward was cleaned by hospital cleaners. I was taken around by hospital porters, and it all worked because they were all members of one team. They weren't all working to other bosses outside. Fragmentation, which you described as part of the scene now, is the problem. What we need is hospitals and institutions like this which are properly integrated. Now my question, please, can you tell me why fragmentation like that is a good idea when all my experience is that it is sheer nonsense? And if you want to improve the health service, then what you need to do is to integrate the system again and get rid of all these private contracts. So my question is, why don't you do that? Thank you very much.
Hello, I'm Kate Godfrey. I'm the Labour Party candidate in Stafford, and I got where I am today by annoying Andy Donald. And it's for Mr. Donald that I have a question. Just one simple question. Is Mark Hackett, the Chief Executive of UHNS, right to think that this is a disaster? Is he right to be frightened that the amount of money that he gets for providing cancer services will be cut in efficiency savings? Is he right to be worried that those services are going to be taken from local trusts? Is he right to think that their finances are not going to stand up against an attack of this type? Is he right to think that there's been no consideration of what this will do to local hospital services? Is he right to say to his oncologist, do you support this? And to publicise it when his oncologists say, no, we don't. Not one oncologist thinks this is a good idea. And are you right not to be listening to those oncologists?
name is Linda McGuinness, and I want to say first of all that I'm disgusted and ashamed at a government that has no rights whatsoever to touch what doesn't belong to them in the first place. And I would like to know, if the government has £1.2 billion to hand out to greedy fat cats, why isn't that money being put into the health service and not given to people to make them rich on the back of every person in this room and up and down the country? You have no rights. Keep your hands off what doesn't belong to you in the first place.
I'll start by referring to my father. I thought it would be helpful to have a personal anecdote. The story wasn't intended to be representative of what's happening in different parts of the country. I offered the suggestion that if you all thought about the experiences you've had and the experiences your family have had, you will probably agree with me about the level of fragmentation and discoordination. Now, why there is the fragmentation is actually it's a consequence of the fact that medicine is getting more specialised. That the place that does your chemotherapy is not the same place that does your radiotherapy. That the surgeon who does your work cannot do the same job as someone else doing it and he goes to a different hospital. So almost inevitably we are getting a more fragmented service in terms of where you go to have what service. The bit that we're missing is how do you keep that all together? How do you orchestrate the journey so that it's seamless? We heard about a very mixed message here. Is it about transformation, and how can it not be about transformation? What we're transforming is the patient experience. The organisational form probably won't change at all. I was really horrified at the misleading stuff you heard, particularly from our MP, about the amount of money that's going to be spent in the private sector. This will almost certainly be spent in the NHS. Mark Hackett's going to be carrying on delivering cancer services. Who else can do it here? So you're being very badly misled. The trick is how Mark's work, along with the community trust, along with the hospices, along with all the other people providing care, can be orchestrated in a seamless way so that if you're going through that journey, you can do it comfortably, with a minimum discomfort, and knowing that someone is sort of holding your hand through that process. That's what's going on.
So no one will make a profit then?
A couple of answers. Kate's answer. Simple answer is, Kate, no, and I've told Mark that. If you believe that UHNS will not be the provider of cancer services in 10 years' time, honestly, it's a different world. I've talked to Mark, and I'm talking to him again in the middle of September about what we're trying to do here. And what we're trying to do, quite honestly, is to work with patients who tell us that their experience of cancer care is good when they get it, but what they tell us is that the system doesn't work to focused on the patient. It's focused on a system. So that's the answer to that question. The second question. Yeah. Well, there's lots of patients, isn't there?
Hang on one moment. Can we just let Answer back?
Okay, and then
I'll let you have questions in a minute.
Yeah. And the second answer to the question about the 1.2 billion. The 1.2 billion is what we spend on cancer and end of life services now, and over 10 years. That is not money that's coming from one place or another. It's money we're already spending over the 10 years on cancer and end of life. And the idea of this whole process is to try and, in the long term, spend more money on cancer and end of life. That's the whole process. And what we're trying to do is make sure that in 2030, when there are 2 million more people across the country who are diagnosed with cancer, that services are actually available for those individuals when they need them. Because the danger is if we don't get this coordination together more effectively, we will find a system that will not be able to cope with the number of people who will be diagnosed with cancer. And that's what we're trying to do here.
Okay, Rachel?
I've just got a question for Dr. Shapiro on the back of that. Why, if there are so many specialists that are leading services, are they not leading the process? The people that work totally committed. We've heard about the oncologists, we've heard about the system of how the NHS used to be integrated. Those specialists who know the service, who know oncology inside out, as opposed to general practice, Why aren't they leading the process moving forward? Is that not the right way of taking this service forward? And if I can say a second thing, I'm very concerned again about what you're saying about the financial commitment and the time commitment in your response there, because those that work in the health service, we all know the rapid change in the way services are being delivered and the technology, the way that medicine is developing at this time. And the reality is, if you tie down a contract today for 10 years, we don't want to be stuck in the past when we come to 2025. We want to be at the forefront of medicine, and therefore what you will be doing is restricting services as opposed to enabling services which could obviously freely flow if they weren't tied down by your contract.
Just picking up on was it Jeff? I think Jeff and Kate and Linda's points. I don't think the government has any right to do this. They forced through legislation, thousands, as I say, of clauses, no scrutiny at all. The UHNS absolutely should be worried, because what will happen, I'm not a gambling man, but I'll put some money on the table for it. What will happen is in a couple of years' time, the conductor, whatever you want to call them, will turn around and say, actually, you know what, this private company has said that they can do this this work really cheaply, and they can push it all through really quickly, so we're going to give that bit of work to them, and Mr Hackett at UHNS, you're going to have to do what's left. And Mark Hackett will turn around and he will say, I cannot make that pay. I cannot do it. I can't afford to do these complex cases with having all the specialists, because all the money that would otherwise be supporting and underwriting that has gone out to these private companies. Is it misleading to say that? No, it isn't. Is it misleading to say that 1.2 billion fixed for 10 years includes the profits for this so-called conductor, and that that's not going to increase over the 10 years, and that's based on the information, the very scant information we have, and therefore those private companies, that conductor, is going to want to make more profit year on year. They're not going to be happy with their £500 per person profit. They're going to want as much profit out of that as they can. Is it misleading to say that? No. Is it misleading to say that at least one member of the Macmillan Cancer Care Board is also a board member of Virgin Care? No, it's not. It's public information. Is it misleading to say the chief executive of Macmillan has recently resigned and moved to the British Council, saying he wants to bring private, public and charity sectors more together? So no, it's not. That's a fact. So is it misleading to be worried about this? No, we should be absolutely worried about this.
Jonathan, I'm just going to let him come back very quickly on one of Rachel's points, and then I'll take 3 more questions.
If you talk to specialists, you get the view of what specialists say. The difference between there's a joke that's said about specialists know more and more about less and less until they know everything about nothing. The GPs know less and less about more and more until they know nothing about everything. The coordination, the journey, to use the analogy, the conductor needs to understand how the orchestra works. He doesn't have to be an expert at the trombones or the woodwind or the percussion. He needs to bring them together. And that is primarily the role of the generalist. That's why I think this thing won't work without the GP's involvement. So I take that point very much on board. The specialist will always resist this sort of thing because they see themselves as threatened. They see that their comfortable way of doing things the way they want to be, which has never been challenged. Now we have someone who's going to say, look, trombones, if we want to, we want you to be part of the orchestra, but you're going to have to up your game here. And Andy's quite right. The chances are that it'll be UHNS that will give us the cancer service because there isn't anyone else. But we want him to come up to the plate and do it better than he's doing it now. The conductor will help us to do that.
Okay, I was going to take 3 more questions. Okay, I'm going to take, you'll keep putting hands, but I'm going to take the gentleman there with the jacket and the red stripe and the glasses there. I'm going to try and take people different. There's a lady at the back with blonde hair and a red top on the avenue, and I'll take this gentleman here with the glasses there.
Yes, Mick Jones. I've never known any privatisation, right, give back money. They're only there for profit. You've only got to look at what the government's done. Railways, gas and electric. They aren't a benefit to the people. You've only got to think of the ambulance service. We had the best ambulance service in the country. Then we lost the contract, and West Midlands took it over. Now it's the worst service we've ever had. These people at the top, right, need to make money. And we're making money for the people who don't care about us. Because half of the top people in these organisations have got private health anyway. Thank you.
Hello, Trudy McGuinness, and I'm Labour's parliamentary candidate for Staffordshire Moorlands. I've spoken to hundreds of people across the Moorlands about this proposal, and I'm part of the Cancer Not-for-Profit campaign team. And the question that people keep putting to me is, why the rush to do this, and why the secrecy around it? What is it that the CCG don't want us to know, and how can it possibly be when profit is the primary motive for private providers? Can this move be the best thing for the people in Staffordshire? And the answer is, of course, it can't. So people keep asking me, and I'm now asking you, why the rush, why the secrecy? Thank you.
My name's Ken Arm, I'm chairman of North Staff's Pensioners on Unite. It's a part question either Rob Fellow or Dr. Lister could answer. A, is it true that if the company who bids for the contract, and is an American, when the next Labour government gets in next year, they can claim for 5 years loss of profit because they won't be able to earn it in the 5 years? And secondly, if NICE were to decide that a treatment for cancer was available, would it not be the American insurance accountants in charge who would say no because it's eaten into their profits?
Do you want to come back on that one?
I'll go first if you want. Yeah, absolutely. Yeah. My apologies to the last question. I was too busy writing and didn't catch your name, so my apologies. But to answer your question, Trudy's a mix, if I may, very quickly. It is about profit. Is the motivation for private companies, otherwise why would they be in business? Why the rush, why the secrecy? Just on the secrecy, at the moment, if the CCG does something, apart from when they declare that it's commercial sensitivity, as a Member of Parliament, I can ask questions under FOI. If the UHNS does something, I can ask questions under Freedom of Information, FOI, Freedom of Information. If it's a private company, I cannot ask questions under Freedom of Information. If they do something and we don't like it and we publicise it, we can't sue them for defamation. We can be sued for defamation, we can't sue them for defamation. So there's a whole problem with having that layer of a private company in there. In terms of the US issue, we've seen this with the tobacco company Philip Morris in Australia suing the Australian government. There's a US company that sued the government of Ecuador over an issue that they felt they'd lost money. My understanding is that if this is done quickly, and the rush and the secrecy, if this is done before the next general election and hopefully we'll get back into government, pretty much we won't be able to reverse this because this will be a tied-in contract, and yes, we would get sued for the remainder of the contract, and it will be driven by, whether it's US or UK accountants, this will be driven by accountants saying, oh, we can't afford this treatment because if we do, it'll eat into the money that we've got this year, let's find another way of delivering the service without that thing. This is why this is so dangerous. You can't do anything about it because that conductor, who in my opinion is going to be completely tone deaf, will be deaf to the pleas and the cries of the people who say we want these treatments, and they'll say sorry, not in the contract.
Just to come back on the rush and the secrecy. If we were rushing it, we wouldn't have taken 2.5 years to get here. It's as simple as that. And that 2.5 years involved hundreds of people, lots of clinicians, lots of debate and discussion about what we're trying to do here for patients and the public. So that's the issue about the rush. The secrecy issue is an interesting one, because I actually agree. One thing I do agree is we have to, as much as we can, be very transparent about what we're doing. You cannot make an assumption, and all of you make this assumption, you cannot make an assumption that if we go out to procure this service, it will be a private provider. You just cannot make that assumption. You cannot. Unless Rob's got a crystal ball that I haven't got, you can't make that assumption. We will, in the middle of September, I think it's about the middle of September, we'll actually be setting out very clearly the organisations that have put forward a bid through the PQQ. So it'll be very transparent. You'll see which organisations are there, whether it's public, private, voluntary sector. What we won't know at that stage, and we won't know at that stage, is whether or not these organisations are partnering together. Because I am on the record to say one of the things that we would hope is that organisations with complementary skills will come together to work together on this. So you might get the public sector and voluntary sector working together. You may not. Do you want me to answer or not?
Okay.
Well, I was just going to say, you can't make assumptions on things we don't even know yet. We don't even know. Therefore, we'll all know in mid-September, and you'll be able to make a judgment in mid-September whether or not you believe your assumptions now are correct or not, won't you?
Okay. I have three more questions. Oops, see everyone. Okay, there's the gentleman at the back with the red jumper on, because he got in really early. The lady there with the other People's March t-shirt on, with the hair there. Everyone's got hair, sorry, that's the stupid thing to say. And this gentleman here who's waving up there. If people keep it short, hopefully we can get round to the other people as well. So, microphone, yeah, you've got the microphone.
Thank you. John Morrie, member of Tusk and Socialist Party. I'm not standing as a candidate for anyone. Firstly, to Dr. Shapiro, you say that one surgeon in one hospital can't perform the same task as another surgeon in another hospital, so people have to be moved around. Surely it's the responsibility of the CCG, who control the budget, to invest the money in those hospitals, to train those surgeons to perform those operations. That's your job. That's what you're supposed to do, to provide NHS care, not to farm it out to the private sector. Andrew Donald, you say there's no secrecy? Then perhaps you care to show us the pre-qualified persons list, also known as preferred bidders. You know the list exists because it was leaked from one of your CCG meetings that wasn't open to the public. Perhaps you care to show us that list and the names on it. I believe Circle Health, Virgin Health are two definite. There's also a private American equity group involved, but no one's quite sure which one. Would you care to show us that list, or would you just like to deny that it exists? Thank you.
Ruth Eagle, member of Cancer Not-for-Profit Group. You say that you want a conductor, and I follow this argument that we want integrated care. I don't think anybody disagrees with that. What I cannot understand is why you do not appoint a conductor or a team of conductors yourselves within the NHS. What you seem to be doing is handing over control of the whole thing to this conductor. The conductor is going to be responsible for spending all this 1.2 billion. If you like, the conductor will be paying all the members of the orchestra, and they will be choosing who is in the orchestra. So they may choose our local hospital, or as Rob Fellow has said, they may choose for bits of it, the nice juicy bits, their particular friends. Why can't we have a conductor within the NHS?
Adrian Jenkins, Stoke-on-Trent Central Labour Party. My question has really just been asked by the previous speaker, but I was going to say this is all. It just seems all so unnecessary, everything that you're trying to do, because there's no need for an external conductor. Surely, if you have a problem, say with your car, with a part of the car, you don't change the whole car. You change the part that's wrong with the car. Similarly with this. If there's a problem with the care not being seamless, and joined up enough, as you put it, then why not make that care within the existing system more seamless and joined up? It's been said a few minutes ago that we shouldn't make presumptions that there'll be a private firm that comes in and takes this. Well, all of the previous large NHS contracts like this that have gone up for tender have been won by, guess who? Private companies.
Yes.
And that's absolutely likely again.
Yeah.
And I would urge you that you should listen strongly, as I know Mr Donald you failed to do, because I was there at the time, you failed to listen to the people that opposed that absolutely outrageous closure of the Margaret Stanhope Centre in Burton. You should listen to the 10,000 people plus who oppose what you're planning to do, and you should call this off before it goes any further.
What I'll do is I'll just let a couple of people come back briefly, and then hopefully we've got, I'm looking at time for 3 more questions, and then I'll let the panel answer those questions, but they can all do a summary as well, and then hopefully we should finish maybe on time, and then I'm sure some of the panellists will be around if you want to speak to them afterwards, maybe.
Okay, well, the first time I probably didn't explain myself very clearly about this thing about specialists. As health services get more complicated and more expensive and more difficult to do, there is an ongoing specialisation. So all of you, again, will have experience that if you're having a straightforward operation done, you'll have it done locally. If you need something more specialised, you'll go to UHB or you might go to London. That's what I meant by the specialisation. Now, how that journey, sorry, I'm going to use the term again, is orchestrated, at the moment isn't done very well. And the point being made is it's exactly what we are doing. We're looking for a conductor. If we just went to Dr. X or Mr. Jones or Miss Smith and said, you be the conductor, then somebody else will come and say, well, it should be me. You have to go through a process. This process is open to any organisation who wants to bid.
No, do it internally. Do it internally. But don't do it externally. That's what we're saying.
I can't answer that. I'm not a lawyer. But what I would say is that what you're seeing compared to other other processes, the reason it's been so slow and so ponderous is because we're trying to do it properly. We get as irritated by our advisors as some of you might, because they are following process to make sure that it is seen to be entirely fair. Now, it has to be fair within law. I'll ask Andy to address the thing about the lawyer.
Yeah, can I just address the secrecy, the gentleman at the back? You clearly know more than I do, because I don't know that. And quite honestly, I don't. So if you'd like to tell me how you've done that, I'm pretty impressed, because I don't know, and I won't know, because I'm not involved in the procurement process. So that's all I can say. So the final thing that Jonathan was talking about is the numbers of things. One thing I'm getting the message is, we're all agreed about integrated care. Actually, that's the message that's coming across. Integration is really important for everybody. And so that's really good. The issue about why can't we do it in the NHS is because we are governed by a set of statutes. And the bottom line is, if we don't go through a procurement process, we will be open to all sorts of legal challenges with regards to that process. From the NHS as well, actually. And the NHS has taken some CCGs to court. But what I'm saying is, we are governed by the statutes that we work with. I don't make up the procurement rules. That's not something I make up. There are issues, but the bottom line is there are things that we have to work within, whether we personally like those rules or not. There are things we have to work within, and they are not being set by us.
Okay, I'm just going to, if you have a question, put your hands up. I'm going to see how many there are. I won't be able to take everybody. I'm going to take the gentleman there with the glasses who's the just wave his hand. I'm sorry, I'm sorry. The other gentleman there with the black t-shirt, and the lady smiling at me with the blonde hair and waving there as well. What I'll do is take those 3 questions, and then I'll ask the panel to summarise their views from the debate and the questions that have been asked, and I'll go through in the same order that they spoke previously. All right, thank you.
Thank you. I'm John Pelfer from Cheadle Labour Party. I'd just like to ask this one fundamental thing, really. It goes back to the confidence that you seem to have in the privatisation, or private companies can do this with. What is the track record? What track record gives you confidence that the private providers will deliver the service that they've tendered for not for the next few years, but for the next 10 years, supposedly, because the track record so far has been abysmal. There have been companies that have walked away, that have staff who've been had their wages cut in various parts of the care service just to make the profits stand up. What confidence do you have that the private sector can deliver, because it will be private sector, it's all lined up for that, there's no doubt about it. What confidence do you have that they will be able to deliver and will continue to deliver? Because we don't have that confidence, and I think the rest of the country doesn't have that confidence, because the track record over the country of where privatisation has occurred has been abysmal. Yes.
My question leads on from that point, but in answering my question, could I ask you, just because I'm a Stokey, not to be patronising to me and use simple cliches like endless, seamless transformation, please, and refer to orchestras, and try and answer me in straightforward terms that, you know, as ordinary people we can understand. Jan Zablocki is my name, from the North Staffs Green Party, but I spent a life in the telecoms industry building a global communications system, and I lived through privatisation of that industry. I saw all of us pay billions of pounds in investment to build a global communication system, a digital system, to the moment it was then privatised. Yeah. And the transformation I saw in that process, from state ownership to privatisation, was one of a constant battering of the people who worked in that industry, who built it and sustained it over decades, having their terms and conditions eroded and reduced for the sole purpose of paying for the shareholders' dividends, the massive pay rises for the chief executives and managers. I lived through it. As a trade unionist, as an engineer and a skilled engineer, I saw it. I wasn't fooled by any of it. Now the question, and I just say this, you know, privatisation is what we're talking about, and my message, by the way, that I'm hearing, isn't about people want seamless end-to-end service, because that's what we think we're getting. I think the message is we don't want privatisation. That's what I'm hearing. When you fail to hear a message like that, it's called cognitive dissonance. You hear something, but you don't want to take it in and absorb the message. You're suffering cognitive dissonance, my dear. Now, because of my experience and what I've seen, my question is this. How can any of you on this panel make the claim that privatisation will somehow mysteriously and magically take money away from the service to pay shareholders, dividends, profits, and, you know, let's Sodexo, the workers are paid a pence, the chief executive is paid in millions. How can you change that economic balance for the better of the great mass of population? This is a political decision, and the politics is all about taking money out of the many to enriching the few. That's what this is truly about. Now, this is a question. Just remind you, you talk about the efficiency of the private sector. Well, we had an example of that, didn't we, with the Olympics. The greatest sporting showcase on earth, G4S. You know? So please, without talking to me in cliches, explain to me how you intend
to privatise something that's working pretty well at the moment, make it work better, more efficiently, but extract millions to pay you rich people at the top and also your shareholders. How does that exactly work other than being a great political con?
I'm going to have to stay sitting down. I hope you don't mind because I'm coaching. I just want to start by dispelling the myth that there has been anything secretive or rushed about this. I'm one of the patient champions. I'm in the patient champion group, and I've got another one with me here. And we've been involved with this for a long time. We've had real input into it, and we're all part of the patient champions group because we've got experiences of the failures of the system. We've all got personal experiences, which, to give an example, we have a lady who was on a ward where she was being treated for cancer. She found a lump in her breast. While she was on the ward being treated for cancer, and she found another lump in the breast, rather than being able to have that treated while she was there, she had to be referred back to a GP and go back through the system again. And that's the system not working. So it's let a lot of us down in various ways, and that's why we're involved in it.
You don't need privatisation. You don't need privatisation to put that sort of thing right. You just need a decent manager.
Do you have a question?
The question is, I mean, I understand scepticism and anger, and I understand fear of privatisation and anger at the government and all that, because, you know, but the question, it's the assumption that it's privatisation. We're involved, we know that it's open to private, to voluntary sector, to public sector, and, you know, we wouldn't be involved if we thought it was privatisation. We are patients. We don't want that either. So, the question... the question is, where has everybody else been? We've been involved for months. You're all here because of an incendiary headline. We've been involved for a long time because we want to improve the system. You're here because of misrepresentation.
Okay, thank you very much. What I'll do is I'm going to ask each of our speakers just to briefly summarise. Obviously, there's been a lot of discussion, a lot of questions from their point of view. And the three questions that are just raised will be part of their summary, just so we can make sure we get through everything. I was going to do them in the same order. So, if Andrew Donald, if you can go first.
Okay. Again, a couple of things to say. Hear a lot of what people are saying, and the audience plus the panel, and I will say this, I'm a little disappointed in some of the misleading comments. And tonight you're not going to be able to have a debate about a lot of that. There is a lot of assumptions, a lot of misleading comments about what we're trying to do. What we're trying to do is actually improve services for local people. That's what we're trying to do. And this is not about. Nobody will agree with me, but this is not about for us privatising.
If we could let Andrew summarise, please. If we could just let Andrew speak, thank you.
Okay. So what I'm saying, this is about better services for patients, and the biggest issue that comes out of this is about accountability. Yeah, one of the messages we're getting back is accountability of the conductor, as Jonathan says. I talk about the integrated care. The CCG remains accountable for the work of the integrator of care, and any major changes that have to be part of a public consultation debate over the life of the contract. There are a number of safeguards in place. The other thing I would say, just to sum up, is that there is a question about transparency. There will be lots of information that starts to be available to people so everybody can see exactly what is going on. But what I think is really important to remember is this is about trying to improve for local people, local services. It's as simple as that. It's not about anything else for the CCGs. Thank you.
Will you answer my question? Will you answer my question? Who gave you the right to take away the NHS from the people? Who gave you the right?
We're not taking away the NHS.
The NHS should not ever, ever be privatised.
Okay, I'll let Jonathan come back on that, and that might be something that Rob will probably pick up as well.
I don't know about Rob, but I've worked in and around the NHS for a great many years, for decades. I've spent my entire career dedicated to the cause of the NHS. I have to work within the rules that the NHS puts around me. I came into this particular role because I was convinced by lots of things, not just what happened here, but experience with patients, experience with my father, experience with around the place, that services are not well coordinated. I have to work within the rules that exist. I'm certainly not in the business of trying to privatise for privatisation's sake. I want to put this out in a formal, a due process way, a proper way, and let the organisation that can best coordinate the care for people who are suffering from serious illness, often terminal illness, to make their journey an easier and more comfortable one. I am constrained by rules that we don't make. We may not agree with them, but they are there. If Rob gets into power, let him change them. We have to work within the rules that we're given, and we're trying to get better services for the people of Staffordshire who are either dying or suffering with cancer, and we're doing the best we can under the rules that we have.
Change the rules. Yes.
And let more people die in the meantime.
Change the rules.
Can I, right, I'm going to pass it over to Rob now.
Thanks very much. Just dealing with the questions first. Mr. Zabocki, is it political? Absolutely it's political, which is why they won't wait until after the election, because then it will be too late for us to do anything about it and change it. The questions from Ruth, Adrian, and I didn't catch the lady's, the patient champion's name, about the NHS conductor, unnecessary, patient champions being involved for a long time, the system not working. Well, 2 points. Firstly, the procurement rules already allow the CCG to commission UHNS to provide cancer services. So that hasn't gone out to tender. Why? So if it's the same rules, and if they are concerned about the rules, again, wait until after the election, and hopefully we'll be in a position to change those rules.
Yes.
So there's no reason to move ahead. If they feel constrained by the rules, wait, and let's get those rules changed. The system isn't working. A little suggestion, UHNS, the fantastic cancer hospital we've got, okay, if we want an integrated system, get Mark Hackett in and say, okay, we're going to give you some of this money, we won't have to pay profits because it'll be the NHS, come in, and you're now responsible not just for the surgery or for the chemotherapy. You're now responsible for that patient until they're signed off by the doctor. You can do that. Make it part of their contract. And the final point in terms of answering the questions, it was actually from the two Johns. In terms of the private sector, I really am not a gambling man. Anybody who's taken me for a few quid will know that. But I tell you what, 100 quid on the table to Donna Louise and the Dougie Mac if there is not a single private provider on the list come September, I will pay 50 quid each to those two charities. Will you match that, Mr. Donald? Because that's what's going to happen. Okay? There is no two ways about it. What we will see, with this goes ahead, is privatisation of cancer and end of life. We will see privatisation of the most vulnerable people in the NHS. If that is stirring up the crowd, if that's raising unnecessary fears, well, time will prove. Time will show. And if you are serious about taking on board the concerns of people, wait. Wait a couple of 100 days. That's all. Hold your horses. If you think this is so wonderful, and no more people won't die, because actually if people are at end of life, they're going to die anyway. And if you're saying, as you've said on public record, that the individual services are fine, then again, why should people suffer? And if there is a problem, you're the CCG, sort it out now. Don't wait for some golden private company to come riding over the horizon. But if you're serious that you really think this is a good move, wait. Hold your horses, get a proper consultation, get people to understand which companies, the private ones, as I'm sure will come out, and I think that 100 quid's safe, except it won't because I'll pay it anyway. We'll see what happens, because quite frankly, these are the most vulnerable. We should not be privatising their end of life and their cancer care.
Yes.
I think we've all witnessed tonight what the future will be, and that is that you won't have a voice anymore. The reality is if this process has taken 2.5 years to get to this point, why haven't those voices been echoed in the work that you've been doing? And therefore, I think that, again, there's a very clear message, and I'm going to ask you direct. Are you prepared to wait to collect those voices until after the general election? Yes or no, it's very simple. You've heard what the public have said. You've heard what the people who own the NHS have said.
There isn't a simple answer because we've heard what a group of the public have said, but there is a population of nearly 800,000 people.
Well, I think 10,000 people have signed a petition as well, so can you tell me, yes or no, are you prepared to wait until after the general election?
We will continue, as we've done, to listen to lots of people with regards to cancer and end-of-life care, and we're continuing to collect information about what we need to do to improve those services, and that's what we'll continue to do. So I'm not prepared to give you a yes or no answer.
Can I say that hasn't answered my question? I said, are you prepared to wait? Yes or no?
I'm not prepared to answer that question.
Well, friends, I think we really do see. I think what we really do see now, what the future is about. No transparency, no direct answers, not prepared to take your voice on board, your concerns on board, you the patients, you the people who care for the sick, you the people that work in the service. Your voices will be silenced because even on something of waiting just a few weeks until we know the outcome of the election, we know what the future will be like under this system. What I would say to you is we know that you do have a voice on May the 7th next year, and I want you to make sure that you turn that date into a referendum on the NHS, and we will get rid of the system, the rules, the lawyers, and all those things we've heard about tonight, and we will reclaim that NHS, and whatever is agreed through this process, we will stop at every point through the next few weeks and months to hold these people to account. And if it means judicial review it will be, because your voices have to be heard in this process.
We on the panel and you in the audience, who, bar one, are accused of being misleading on what they're trying to do. I would say one of the reasons we may or may not be misleading on what they're trying to do is because they haven't told us what they want to do. All they've told us is they want the best of all worlds, they want a seamless care, etc., etc., but they haven't told us what it would look like. And it's okay, it's okay. Look, they can even argue they don't want to privatise cancer care delivery, although they do say they want to transform it and completely change it. So, you know, we can leave open what that form might be, because we still aren't told. But the reality is they are certainly talking about quite likely privatising the control over those cancer services, because the conductor is almost certain, given the situation I've discussed, to be from the private sector. And they're going to have... let's look at an example of this. We've already got in Cambridgeshire, in Hinchingbrook Hospital, we've got a private company which is actually, it doesn't own the hospital. Circle is running Hinchingbrook Hospital, okay? They're running it in order, desperately trying to seek a profit, which haven't made yet, but it doesn't mean they don't want one, okay? Then, if we go to Bedfordshire, we just had the musculoskeletal services handed over to a consortium headed up by Circle, who now decide how those services should be run right across Bedfordshire. In Bedfordshire, we've also had dermatology services handed over to United Health, an American multinational, has moved in, rebranded itself as Optum. They've taken those services over there. Both of those were pushed through without any public consultation whatsoever. In Cambridgeshire, when they're moving now and they're about to announce who the preferred provider is for their older people's contract, a £700 million contract for older people. In Cambridgeshire, they also wanted to push this through without consultation, without publishing any of the documents. And in the end, a local campaign was strong enough and managed to mount a legal challenge, and got a legal challenge that forced Cambridgeshire, actually, rather than go to court and find that it didn't have a legal basis not to consult, they were forced to open up a consultation. And I think we should look the same way here. These people have to have a consultation on a change this big to a service this important to local people. There's at least here a sufficient body of numbers to suggest, and all the 10,000 signatures, to suggest a serious level of public concern. People are not convinced by what they're being told by these CCGs, and they need to go to consultation. If you go to consultation, then okay, if you can show that a serious body of public support, if you ballot the GPs and show the GPs actually know what's going on and support it, then we might have a different type of discussion. At the moment, we've got secret documents we're not allowed to see. We've got a plan that doesn't exist as far as we know. We've got no idea what it is. We've got a business plan that certainly doesn't exist, otherwise it would have been published by now. And we've actually got this process being done without your involvement whatsoever, running through token levels of involvement. And we've got a CCG that has the power, if it wants to change these things for the better now. They could actually call these chief executives in of these trusts and get them to work better along these lines. They could actually point out these problems. The problem that was mentioned by the patient champion, they could say, right, sort this now. Sort it now. And if they refuse, then if the CCG can come back to us as the public, we can put the pressure on to get it sorted out. Okay. Can be done. Can be done. There's no need, there's no legal need, there's no necessary need whatsoever to go to tender in the first place. There's no need to rush it through. There's no plan set out in any legal document saying how fast you have to do this process. You can slow it down. You can stop it now. Stop it now before somebody gets hurt. Stop it now while the NHS is still intact in Staffordshire. And let's actually have a more serious discussion. If you've got plans how that should be organised, tell us what the plans are. See if we can actually agree on what the plans might be. But if what you want to do is behind closed doors sign off a contract for private people to take over the running of cancer services, I don't think you're going to find many people in Staffordshire are going to support you, if any. And I think that on that basis, a consultation, absolute must. And the scrutiny committees of the various councils and so on involved need to step in and demand a consultation before they sign off on any of these closures and force it to the Secretary of State for a decision. Let's actually demand our voice, our say, and stop this nonsense before it goes through courts.
Thank you. I apologise for my voice, I've got problems with it. But all I want to say to you, I'm an ordinary member of the public, my name's Maureen Booth, I'm not affiliated with any politics whatsoever. I was diagnosed with breast cancer in October 2012. And the care that I received at the North Staffs Hospital has been, from then until now, second to none. And I think that the staff at the North Staffs Hospital that treated me are absolutely brilliant. And I cannot fault them at all. And you can't convince me by going private that you can improve on the system and the care that I have had. Thank you.
as an NHS worker, it is really nice to hear positive comments about my colleagues, because sometimes we don't actually hear that feedback. Often we get negative stuff. So I will share that with colleagues and with that. So thank you very much. I'd also like to thank all of our speakers from the floor and from the top table. It's been a lively debate. I think we can all agree with that. I know that Andrew and Jonathan have said they are going to be staying around for a while if you wish to speak with them. I think, yeah, John has to leave, yeah, and Rob has to leave and Rach has to leave, but Andrew and Jonathan have said they'll stay for a little while, yes. If they start heading towards the door, then, you know, I'm not responsible. But thank you for everyone for coming. You're aware of the petition to the TTIP, so please and thank you for coming along. Thank you very much.